one it doesn't need any introduction. He's one of the famous laryngologists in the intervention, especially in a very modified settings, not a conventional way, and he's here to talk about exercise-induced laryngeal obstruction. Thank you.
Thank you very much, Jay, and thank you for the promotion. Not a professor yet, but hopefully soon. So thank you very much.
All the
And thank you very
in my view, all the laryngologists are professors because they do all.
Thank you very much.
Yeah.
So thank you very much for the invite. And as you rightly said, this is in a bit unusual subject and not very well understood or recognized in many cases. So I'm just going to try to discuss the etiology and pathophysiology of exercise-induced laryngeal obstruction. We look into the clinical presentation and management option. So the term inducible laryngeal obstruction is an umbrella term that encompasses a variety of conditions, which all characterized by inappropriate reduction of the airway diameter at the level of the larynx during inspiration, either by closure of the vocal cord or collapse by the supraglottic structure. This used to be termed, there are many terms that used to be popular in the past: vocal cord dysfunction, paradoxical vocal fold movement. And since 2013, there has been a consensus between the European Laryngological Society and the European Society of Respiratory, where they introduced the term inducible laryngeal obstruction. So it has multiple phenotypes. So you will see the classic EILO, where you will have these episodic breathlessness, patient described tight throat, often triggered by odors and irritants. There is also the lung disease associated EILO, which is mostly breathing pattern disorder. So the patient incorporates some compensatory mechanism for their breathing to improve breathing that lead paradoxically to worsening of symptoms. You will have incident association, which we all see in these patients coming to accidents and emergency following a stressful life event, etc. And the subject of our talk today, which is the exercise-induced laryngeal obstruction, which we see in athlete as a response to exercise. So EILO itself is not a new thing. It was first described in 1869 by Sir Moran Mackenzie, who's the father of British laryngology, or I would argue the father of laryngology worldwide, where he described intermittent abnormal movement within the larynx, which he observed with a mirror examination, which was technology that was available at the time. Over the years, this has been over 100 different terms used to describe this collection of conditions, initially thought to be psychogenic, being referred to as psychogenic stridor, Munchausen stridor, irritable larynx syndrome, etc. So exercise-induced laryngeal obstruction, the prevalence is quite high compared to what we would think. So this is between 5 and 8% in adolescent or young adult athletes. The onset is often around 13 years old, 13 to 15. There is female predominance, and it is common in competitive athletes. So people who actually in like Olympian or training for Olympic, competitive sport, you will see much higher incidence compared to people on PE sessions, for example. So just to start on the pathophysiology, I thought I will go through some principle of airway biodynamic. And I know Mr. Sam Majumdar covered some of these, but this is like a different take. So airflow happens when there is a difference in pressure between 2 points, which are the intrathoracic pressure and the atmospheric pressure. And the difference between these two is termed the driving pressure. The flow rate is the amount of air we move in 1 second, and this is what we rely on. So the amount of air we move in 1 second corresponds to the amount of oxygen we're taking. The flow velocity, however, is the distance the air travels in 1 second. So that's the actual speed of the airflow. And the two are related, and they are related to the cross-sectional area of the tube. So if we need to keep a stable flow rate, or we need to increase the flow rate because of the increased oxygen demand during exercise, and there is, at the same time, there is a narrowing of the cross-sectional area of the airway, then we need to increase the flow velocity. And that dyspnea, patients start breathing quite fast to try to move the same amount of oxygen through a narrower space. The second important principle is the flow pattern. So there is the laminar airflow, and we see this in a normal diameter airway. You will see the air is flowing in layers. So the central layer is the fastest, and the peripheral layer are slower, and there is a gradient in between. And this is a very energy efficient way to move air. So the flow rate here is proportional to the driving pressure. You increase driving pressure, you increase the flow rate. However, the turbulent airflow, where we will have a random pattern of airflow, there will be radial, axial airflow. So the air is flowing along the tube or along the airway, but there is also radial flow where there will be a constant pressure from the air onto the walls of the airway. And that consumes a lot of energy. So it requires a much higher driving pressure to move the same amount of air. So that's when the patients start becoming increased work of breathing. They're trying to breathe deeper to lower their intrathoracic pressure disproportionately to what they do if the airway diameter is normal. And you will see this pattern on these computer simulations. So this is work from the aeronautical engineering at Imperial College, Professor Durley's group. And you can see here on the left-hand side, if you look into normal diameter airway, so that's trachea, glottis, you will see how the air is flowing in laminar flow with very little turbulence. Have a small narrowing, and you started to see that turbulence of the air have a significant narrowing, and there is now significant turbulence. So here there is a lot of loss of energy in terms of airflow. And that's very important. The second figure is also extremely important. So this is a cross-section of the glottis. So that's front, back. So you will have the vocal fold and the arytenoid. And if you see where is the vast majority of airflow happen around the posterior part of the larynx. So obstruction in this area or narrowing of this area will significantly impact the airflow compared to obstruction in the front. And similarly, improving the airway slightly at the back will lead to disproportionately improved breathing compared to trying to take large part of the vocal cord. And although not subject of this lecture, that's why I would never do a cordotomy. I will always do a retinoidectomy if I need to in cases of bilateral vocal cord immobility, because small gain in that posterior glottis will lead to significant improvement of the airway with minimal impact on the patient voice compared to a cordotomy. So how does that manifest itself in EILO patients? So in a normal situation, in normal individuals, when we are at the peak of exercise, you will see that the vocal folds and the arytenoid are fixed in a relatively abducted position. So there will be no movement on inspiration or expiration. So if you're scoping people, normal pattern, the airway will be stable and there is a airflow in and out. You will see flattening of the epiglottis against the tongue base, and that leads to stretching of the aryepiglottic fold, so it's not collapsing within the airway. In patient with exercise-induced laryngeal obstruction, you will see the obstruction happening either at the level of the glottis or the supraglottis. The patient can have either one of these. So some people will experience glottic, some people will experience supraglottic. They can happen in parallel, so they will have two-level obstruction, or sequentially, which is possibly the most common. You will see that the prolapse start at the supraglottis, and then they start engaging the glottis, and then you will start to see narrowing at the level of the vocal cords. And what you observe with that supraglottic pattern is an inward prolapse of the arytenoid cartilage, the aryepiglottic tissue, or in severe cases, you will see epiglottic collapse even. So the etiology remains unknown. There are various different theories. That is, you can look into like airway dynamic, just like, is it just simply a collapse? They're trying to correlate that to patient who had laryngomalacia, but there is up till now neurological maturation. None of that is like absolutely 100% understood, not as yet, but there is a lot of work happening within this area. There are risk factors that we see often in these patients. So asthma is a risk factor, but also there is high chance of association between asthma and EILO. Reflux can be seen in these patients, although treating reflux have no impact, no positive impact. So you treat reflux because they have symptoms of reflux, but it doesn't improve their exercise-induced laryngeal obstruction. we see a higher incidence of rhinitis within this patient group. There is anatomical factor that's thought to be relevant. So narrower size, smaller size larynx might explain it because you will have disproportionate narrowing of the airway, and the smaller airway, if you narrow it further, that's the Poisson equation, you will have the difference in airflow will go to up to the power of 4. So, and that's possibly explain why female athletes will have this more than males, because there is narrower airway to start with. So when you narrow it by a couple of millimeters, this becomes significant more than in a tall, big young man when they have a much bigger airway. There are behavioral health factors. So patients, the way breathing pattern, have they had like appropriate training? Do they warm up? Do they have the appropriate support structure and coaching around them? There is some research looking into genetic factors, although there is no genetic link that has been confirmed or specific inheritance pattern, but we do see that sometimes in families. The psychological characteristics is an interesting one because if you look into compare the general population between normal population and ILO patient, you will see increased levels of anxiety, you will see increased level of personality disorders. However, it's not thought to be the cause of ILO, but it possibly heightened the level of anxiety, leading to a modification of ILO. So it makes the attacks to be stronger and the patient less able to cope with it. So how do these patients present? So we see this at the peak of exercise. They will have dyspnea, stridor, dysphonia. They describe throat and chest tightness and increased anxiety. It resolved very quickly. And it's classic for this patient group that they get diagnosed with asthma. So a young man or a young woman start developing these symptoms. They get seen by their GP often as a first line of call. They get mislabeled as asthmatic, given bronchodilator, given steroid inhalers. Nothing work, and then they get escalated, treatment get escalated, and it takes a while. Sometimes it takes a few years before they get the right diagnosis. And we see that this is something common not only in this group, but in general in airway stenosis cases. You see that pattern exactly the same in idiopathic subglottic stenosis, for example, which Mr. Majumda has alluded to earlier. So what will make you think that this is ILO or this is asthma or exercise-induced bronchial spasm? In ILO, it's mainly an inspiratory problem. So there is wheezing, whistling, stridor on breathing in, while in asthma, it's mostly an expiratory problem. It's a wheeze, it's expiratory wheeze. With ILO, it peaks at the peak of exercise. So the symptoms will start, and as they increasing their as they're getting more dyspneic, as they increase their breathing rate, you will see these symptoms picking up. And at the peak of their exercise, that's when they have the most symptoms. While in asthma, it peaks after stopping the exercise. So with ILO, you stop exercising, and within 1 to 5 minutes, it's resolved completely. You just need to stop, and it just settles down. While with asthma, it peaks, in fact, like 3 to 15 minutes later. There is also the response to bronchial dilator. With ILO patient, they do not respond to bronchodilator, while asthmatic patients do. So how do we work these patients up? So you see those patients, they're typically are completely normal at rest. So they have completely normal examination and absent symptoms. So this is a classic isolated ILO presentation. If you see resting stridor or resting wheeze, you need to evaluate for other airway pathology. This is not ILO. It could be a combination. As I said, there is high rate of coexistence of asthma and ILO, but ILO itself should not have any symptoms at rest. If you do spirometry, again, is often normal. Sometimes, like some studies describe like inspiratory flattening. However, the diagnostic value of that remains controversial in at rest. Imaging, you don't need any imaging for ILO diagnosis or workup, but you can include that if you are trying to exclude other pathology. So laryngoscopy is the gold standard. So as I said, laryngoscopy at rest will be normal, completely normal. You can do exercise laryngoscopy, which is provocation. You send the patient to exercise, and then as they come at the end of their exercise, you can put the scope and see what's happened. And that will be appropriate for resource limited, or if you don't have a lab that can allow you to do the continuous laryngoscopy during exercise, which is the gold standard. So with that last one, you will have a real-time visualization of what's happening in the larynx. And if you look here at the lab in the Royal Brompton Hospital, we'll have this harness that fits on the patient head, and they will have the scope that's going into the airway fixed at the nose and looking at their larynx continuously. And within this lab, we have a various different exercise machines. So we try to match it to the athlete individual sport. So here you can see somebody on a rowing machine. We have treadmill, we have exercise bike, and then you try to simulate it as much as you can. In other labs, although we don't have that at Royal Brompton, you can have it even in a swimming pool, like one of these rolling pool, and you can do that. So it's amazing what stuff people can tolerate with a scope down their nose. And what do we see? So in a normal individual, you will have that what we call a grade 0. So at the peak of exercise, the glottis will be open with no inward movement of the vocal cord, and that will be grade 0. And similarly, grade 0, no onward movement in the arytenoid. Grade 1, with the glottic pattern, you will see inward movement of a narrowing, but with no perceived rotation of the arytenoid. So that's the soft tissue of the vocal cord is being pulled inward, but without an actual rotation of the arytenoid. Grade 2, you will have closure, so movement of the arytenoid, but without contact, and grade 3, complete closure. In the supraglottic pattern, in grade 1, you will start to see some rotation of the arytenoid and the corniculate cartilage, so the suprastructure of the arytenoid and the corniculate cartilage. Grade 2, you will have like a lot more pronounced, and you can start to see the lateral mucosa coming into view because it's really pulling inward. And with grade 3, you will have a complete contact between the suprastructure of the larynx, narrowing the airway significantly. So what's the differential diagnosis? What do you need to exclude as you're working up these patients? You need to exclude exercise-induced bronchospasm, and that's something that is quite common. As we alluded to before, it's often expiratory, it's post-exercise, and respond to bronchodilators. There is cardiac disease you need to exclude, and anxiety attack, airway abnormalities such as subglottic stenosis and tracheal compression. And the management of EILO is really a team sport. So this is not something you can do on your own as an otolaryngologist. You need that wider multidisciplinary team. You need respiratory physician who need to differentiate EILO from asthma. Often in the UK, mostly it's been led by respiratory. So the unit that manage athletes to high-level athletes are mostly based within respiratory units. You need the otolaryngologist ourselves to do airway evaluation, to perform surgery if required. And possibly the most important member of the team in terms when it comes to management is speech and language therapy and respiratory physio, and as the mainstay treatment is respiratory retraining. You will need the support of psychologists in terms of offering behavioral support, managing anxiety, performance issue that the athlete might face. So as I said, it's a multidisciplinary approach. The first line is speech therapy and respiratory training. There is adjunct treatment such as behavioral therapy, reassurance, biofeedback, which is often led by sports psychologists. Bronchodilators are ineffective in these patients, so there is no role for pharmacology unless there is asthma coexists with EILO, and there is no role for inhaled steroid in isolated EILO either. Now, our part, surgical management, this is very rare. So we do not do that for everyone. This is often reserved as a last resort for only refractory cases that fail to respond to all other treatment. And it's only applicable to when you have supraglottic pattern, because you really, for somebody with a completely healthy larynx, you do not want to be doing arytenoidectomy or chordotomy on these patients, leading to significant side effects from voice, etc., to help with obstruction at the level of the glottis. So this is completely inappropriate. However, when it comes to supraglottic collapse, then we can intervene and we can offer supraglottoplasty. And I will show you a video on how this procedure performed. So you will see here, we're doing this with jet ventilation. We use a subglottic catheter rather than a supraglottic catheter. You need to assess for joint mobility, make sure that there is no joint fixation or dislocation. And the reason we use subglottic catheter is we can put that patty in the airway to protect the vocal cord. So if you're using supraglottic airway, that often gets blown inside. So just be careful with that. Otherwise, you will have to go and fish it out from the bronchi. So you start by dividing the epiglottic fold, and again, you need to tailor your surgery to the pattern. So seeing the pattern of prolapse during exercise will determine which area is the predominant factor and where you need to direct the majority of your treatment, your resection. So you see here that we separated that arytenoid from the epiglottis. So that's got divided. And now we are paying attention to the corniculate cartilage, which is sitting on top of the arytenoid, and we're trying to resect that. So it is very important to respect the height of the posterior height of the arytenoid because that will help prevent aspiration. It's not particularly relevant in this age group. They are 15 years old to 18 years old. So they really not gonna have aspiration. But if you're doing supraglottoplasty, let's say for unilateral vocal cord palsy in an elderly patient, you need to pay attention. And you can see here the final result doesn't look pretty, but it heals very well. You can see here that the tip of the arytenoid pyramid is exposed. Often, if it is the height is still high, or I've seen like a great degree of inward prolapse, I will take the laser on a round shape and I will try to reduce the height. Two very important consideration, you should always remain above the level of the vocal fold. So you should not go down into the subglottis with your laser resection because then the the thermal injury can fix your cricothyroid joint, and this is a disaster for the patient. The second extremely important factor is to leave a decent bridge of normal mucosa between your resection because that will prevent posterior glottic stenosis. Again, a disastrous complication if this happened for a patient with healthy larynx otherwise. And you will see the impact of that. Sorry, the video is not great. The patient is an exercise bike, but you can see here how's the arytenoid prolapsing on both sides. As they increase the speed, you can see that prolapsing and prolapsing. While if you look into her post-surgery, you see the larynx heal remarkably well. But now she's exercising, she's getting to the point that when her body can't cope anymore, but her airway is coping very well. So she's not having any wheezing, and it led to significant improvement. And that can make a difference. You know, we have Olympians that we perform this surgery on in our center, and that's 5-10% margin is a difference between no medal and a gold medal. So this is quite transformative, but the patient selection is extremely important. And on that, I'm happy to take any questions.
Good. Wonderful talk, as usual. Nice photos, very intellectual. I fully understand. Case selection is a key. Chad, can you see the Q&A, please?
I see the Q&A.
So leave the first few questions that belong to pediatric.
Yeah.
So I think you can start from, I think, Kate.
Is there a role for CPAP in EILO? Not in EILO as such, no. CPAP, you're going to use CPAP. CPAP is going to be used at night. There is a role for CPAP for sure if the patient have laryngotracheomalacia, and that might be a contributing to their sleep disorder breathing, yes. But like for an isolated, for EILO per se, where there is paradoxical vocal cord movement or prolapse of the arytenoid, there is no role for CPAP in this population.
That's good. I don't think there is any questions. I think many give a nice feedback on the chat. It's a very useful talk.
Thank you very much.
Chad.
There is a hand up from Dr. Ahmed Youssef. I don't know if they can.
Yeah, you can call. I can ask. Ahmed, you can unmute.
Thank you very much for your talk. I already typed my question regarding the arytenoid trimming. I'm really surprised about it. And my question is, have you been seeing any granuloma or granulation following this? Or I understand about leaving the mucosa between the arytenoids to prevent any stenosis. However, leaving the arytenoids is quite exposed. Are you having any seen any cases complicated by granulation or granuloma, especially in those kids?
No, granuloma per se is different from granulation. So the vocal process granuloma is when you leave exposed um, perichondrium at the level of the vocal process. But conditional to that, that you need that squeeze, you need that rubbing against the other side. And that's a typical vocal cord granuloma that is very difficult to treat, that we all struggle to manage. You know, you see that with voicing pattern, etc. Granulation tissue is part of the healing process, and you can see granulation tissue. It heals very well, I will have to say. This is healthy larynx. There is no underlying pathology. There is no underlying inflammatory condition. You will get granulation. The granulation heal. We don't see granulation that often. You will see that sloughy area, that fibrin plug that happen as part of the healing, and then it epithelialized very well. So not
Okay.
particularly a concern. Is the main thing. It's key that you don't go too deep. Fixing the
Mhm.
joint is a disaster. Posterior glottic stenosis is a disaster. And although I'm showing this is like really rare surgery. It's not every patient who comes with EILO we put for an operation. This is for when nothing else has worked.
Okay, thank you.
Chad, there's two more questions.
Yeah.
How do you, can you see this? Which centers in the UK have the facility to access to treat ILO?
So Royal Brompton Hospital and Manchester. I'm not sure if there is anyone north of the border in Scotland that have like proper, exercise lab, etc., that offer the service. But in England, there is Manchester and Royal Brompton Hospital are the two biggest centers.
And there's one more question. How do you medically treat this condition in the first setting rather than referring to a
Sorry, I
respiratory?
missed that.
How do you medically treat this condition in the first setting rather than referring to a respiratory therapist?
Well, there is no medication that works. So for no specific medication work, we see patients. So looking into ILO or vocal cord, dysfunction in general, when a patient show up to ED, they end up getting nebulizers, they end up getting steroid, they end up getting adrenaline nebulizers, heliox, all of that stuff. I don't think much of that works. So there is a very large placebo effect as long as you are confident that there is no other pathology that you're missing. So if we are confident that this is just paradoxical vocal fold movement, reassurance is plays a large part, not always possible. I see patients that we admit to hospital, unfortunately, and they come in for monitoring overnight. You see patient getting steroid. I try to demedicate the situation as much as I can. I'll try to avoid giving medication as much as I can. I think saline nebulizer is possibly as effective as adrenaline nebulizer. It just gives that a little bit of that placebo effect. So try to be conservative with your medication, but you need to get the right balance. There is a lot of psychological aspects associated with it. Patient is anxious. They're in your emergency department. So you need to tailor your management case to case. But with nothing else, I don't think any of the medication offer much help beyond placebo effect.
Good. And do we need to suture the mucosa over the retinoids or can we leave it exposed?
We leave it exposed. It just epithelialized.
And I think it's not relevant to this talk, but it's a good question. Any laryngologist can answer. Is it possible to identify superior laryngeal nerve palsy in fiber optic laryngoscopic examination? What is the findings on FOL?
Um, People say they can. I'm not sure you can, not reliably. I think occasionally you can see that reduction of tilting or like difference between the two sides. I think it's very rare that you will be able to reliably identify it. I think you need to go by, I think history, etc., plays a role. Laryngeal EMG it's not always accessible, and that doesn't change what you do. So we don't do EMG that often, but on EMG you can.
That's a
I
very
don't
good,
know if others have the same view or different views.
I think that's a very good answer. Okay.
Yeah.
Thank you. That's brilliant. Thank you, Chad. And I think we move on to the next one.